Welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we are shifting gears from beta blockers to another cornerstone of chronic disease management. This time, we are diving into the world of osteoporosis, and our focus, Alendronate, one of the most prescribed bisphosphonates in both primary and specialist care. Alendronate has changed the landscape for managing postmenopausal osteoporosis, glucocorticoid-induced bone loss, and even Paget's disease. Now, if you are a pharmacist preparing for the board exams or currently navigating practice in a retail or hospital setting, this is an episode you absolutely need to master. Alendronate is one of those drugs that shows up everywhere. On OSCE stations, in patients' counseling challenges, and in clinical decision-making dilemmas. Yet so many errors happen around its use, from improper timing to missed red flags and renal impairment. So today, we will decode its mechanism, nail down the dosing, highlight the dangers, and walk through practical real-world pharmacist scenarios. Before we jump in, make sure you have joined our Telegram and WhatsApp study groups, where we review board-style cases, exchange drug tips, and break down difficult topics together. If you are on LinkedIn, let's connect professionally. This community grows stronger when we share knowledge. Let's start with the foundation. How does Alendronate actually work? Alendronate belongs to the bisphosphonates class and works by inhibiting osteoclast-mediated bone resorption. It binds to hydroxyapatite in bone, and when osteoclasts attempt to resorb this bone, Alendronate is released and disrupts the osteoclast function, ultimately reducing bone turnover. The net result? An increase in bone mineral density and a significant reduction in vertebral, hip, and wrist fractures. It is a preventative and treatment agent, but it is not a fast-acting pain reliever, something patients often misunderstand. In Canada, Alendronate is indicated for treatment and prevention of osteoporosis in postmenopausal women, osteoporosis in men, glucocorticoid-induced osteoporosis in patients on systemic steroids, treatment of Paget's disease of bone. The most common formulation is the oral 70 mg once weekly tablet, although daily 10 mg dosing exists, but it is less frequently used. Now, let's dig into the real practice critical section, dosing and administration. Alendronate's dosing protocol is strict, and for good reason. It has extremely poor bioavailability, less than 1%, and is significantly impaired by food, beverages, and certain medications. Here is how to ensure it's taken properly. Patients should take one 70 mg tablet once weekly, first thing in the morning, with a full glass, at least 240 ml of plain water. Not juice, not tea, not coffee, just water. They must remain upright, sitting or standing for at least 30 minutes and delay eating, drinking, or taking other medications for at least 30 minutes post-dose. This minimizes the risk of esophageal irritation or ulceration, one of the Alendronate's hallmark concerns. It's also important to counsel patients on consistency, same day, every week, same time, and no doubling up if a dose is missed. We cannot talk about Alendronate without a thorough look at adverse effects and safety concerns. The most prominent include upper gastrointestinal irritation, dyspepsia, esophagitis, ulcers, and even rare esophageal perforation. This is why proper administration is not just a suggestion, it is a must. There are also reports of musculoskeletal pain, sometimes severe, and rare but serious risks like osteonecrosis of the jaw, particularly in patients with poor dental hygiene or those undergoing invasive dental procedures. Atypical femoral fractures have also been reported with long-term use, especially beyond 5 years. Alendronate is contraindicated in esophageal abnormalities delaying emptying, like strictures or achalasia, inability to sit or stand upright for 30 minutes, hypocalcemia, severe renal impairment, eGFR less than 35 ml per minute. We must also evaluate calcium and vitamin D intake. Patients must have adequate levels of support Alendronate's efficacy. Pharmacists should proactively assist for supplement use and potential interactions with calcium, magnesium, iron, and antacids, which can interfere with absorption if taken too close to dosing. Let's look at how this plays out in real pharmacy practice. Case 1. A 73-year-old woman is picking up her new prescription for Alendronate. You review her file and find she's also taking ferrous sulfate in the morning. You counsel her to separate these by at least 30 minutes to an hour post-Alendronate and confirm her intake technique using the DREAM model. Case 2. A man in his 60s comes in with a complaint of increasing hip pain. He has been on Alendronate for 8 years. This triggers your awareness of atypical femoral fractures. You refer him to his prescriber for reassessment and possible drug holiday. Case 3. A patient with a history of GERD is prescribed Alendronate. She reports severe reflux even with proper intake. You flag this to the prescriber and suggest a possible switch to a different agent, such as denosumab or IV bisphosphonate lysohydronic acid. Case 4. A patient fills Alendronate for the first time and admits to lying down right after taking medications due to fatigue from a recent surgery. You strongly advise against this. Explain the esophageal risks and set up a plan to adjust timing or re-evaluate. Case 5. A cancer survivor on Alendronate and concurrent chemotherapy is scheduled for dental extraction. You proactively warn about osteonecrosis risk and coordinate with the prescriber and dental team to adjust therapy as needed. All of these cases show how pharmacists can catch errors and intervene for better safety and outcomes. Quick shout out. If you want more structured case walkthroughs like these, join University's clinical series. We take complicated cases and simplify them for your board prep and daily practice. You can also jump into our live group discussions via WhatsApp or Telegram using the links in the show notes. Let's do a quick dream counseling group play for Alendronate. Remember, DREAM stands for directions, reason, expected onset, adverse effects, and monitoring. Pharmacist: Hi Mrs. Taylor. I see you are starting Alendronate for osteoporosis. Let's go over it together. You will take one tablet once a week on the same day each week. Take it first thing in the morning with a full glass of water, nothing else. After taking it, stay sitting or standing for at least 30 minutes and do not eat, drink, or take other medications during that time. This medication helps prevent bone breakdown and strengthen your bones, reducing fracture risk. You won't feel anything right away. This is a long-term medication. Some people experience upset stomach or heartburn. That's why posture and timing are important. Let's know if you feel any chest pain or trouble swallowing. We will monitor your calcium and vitamin D intake and check in with your doctor every few years to reassess if it's still needed. Any questions? And now, let's do our rapid fire Q&A to lock in the knowledge. Question 1. What's the primary risk of lying down after taking Alendronate? Answer: esophageal irritation or ulceration. Question 2. Can Alendronate be taken with calcium supplements? Answer: not at the same time. Calcium interferes with absorption and should be spaced apart. Question 3. What is the recommended duration before considering a bisphosphonate holiday? Answer: typically 5 years, especially in low-risk patients. Question 4. What should be done before initiating Alendronate? Answer: ensure normal calcium levels and assess renal function. That wraps up today's episode on Alendronate. You now have the tools to counsel, monitor, and intervene like a pro. Do not forget to subscribe and share this with your pharmacy circle. And of course, join our Telegram and WhatsApp study communities for even more. That's Momin Wali signing off from the Therapeutics Chronicles. Catch mistakes before they catch you. See you then.